Hello, my name is Van de Keyser. I am a neuroradiologist working in Ghent University Hospital in Belgium, and welcome to this video presentation on the neuroanatomy of language. In this presentation, I'm going to talk about the anatomy of language, which is a quite complicated topic, which also has a very long history. In this presentation, I'm first going to give a short introduction on what is language exactly. Then I'm going to discuss the classical language model or the classical anatomical model of a language as described by Pierre-Paul Broca, Wernicke-Lichtheim-Geshwind, the model that is actually still considered the golden standard and is presented in a lot of handbooks on this subject, but is a bit outdated and a bit flawed. I'm going to tell you why that is in the third section of this presentation, limitations to the classical language model. And then, but this will probably be in a follow-up presentation because otherwise this presentation is going to become quite long. I'm going to talk about studying language in the healthy brain with use of more modern imaging and research tools such as functional MRI and PET. And I'm going to discuss some new insights concerning language, the functional anatomy of language. So let's get started with a short introduction. What is language exactly? And when we talk about language, a lot of people automatically think of language as something very narrow, so a system of communication used by a particular country or a community. And there are about 7,000 languages that correspond to that definition. For instance, what I'm using now, English, but could also be German, French, West Flemish, Swahili, Navajo, and so on and so on. That is a very narrow definition of language, and it basically says that there are about 7,000 different languages out there, but we're going to talk about the anatomy of language. We're not going to talk about the anatomy of the French language. We're not going to talk about the anatomy of the German language or whatever, because at the end of the day, all these languages or represented or activate a similar system in the brain. So there is, when talking about language, we talk about something that encompasses all these different narrow languages. We're talking about a system that is located somewhere in the brain, a computational system that basically allows the transformation of thoughts into an acoustic signal. And this is a multi-stage computation. It involves multiple steps and it is performed with imperfect fidelity because that's something we all know from daily experience. We're simply not always able to translate our thoughts into words in the best possible way to convey our message. And the other thing also happens when somebody says something to us that we incorrectly interpret what has been said. So it happens with imperfect fidelity, but it's still a pretty good system because it allows the translation of our inner thoughts into a acoustic signal. And that acoustic signal is generated by a motor system. It involves the larynx, it involves the mouth, the tongue, the hard and the soft palate, the teeth, and so on. All these structures are involved in the process of articulation. And by articulating, we make the air vibrate, we generate air waves that then land on the ear of a listener in the form of an acoustic signal. And this very same language system, this computational system located inside our brain, translates that acoustic signal in a certain meaning, an idea. So basically, a language allows telepathy. It allows us to transform our ideas into the head of somebody else, and it allows other people to do the same with us. But we need that step in between. And I'm talking about acoustic signals, but we can also write. So there can also be a visual system, or it can also be visual signals. There is a sign language, for instance. So it's more than just spoken language when talking about language. It involves more than spoken language. But when I'm just talking about language here in this presentation, I'll generally mean spoken language. I'm not going to talk about written language or sign language and so on. A language has several components. So We have phonetics, and phonetics is basically the study of sounds, but on a physical level. Then we have phonology, which also involves the study of sounds, but on a more abstract level. I'm going to make the distinction more clear in the following slide. Then we have morphology, which concerns the study of words. We have syntax, the way words are combined into phrases and sentences. We have semantics, which is the study of meaning. Words have certain meanings, and then we can have synonyms, words with the same meaning. We can also have compositional semantics, which involves a meaning that is determined by the position of words in a sentence, and so on. So semantics, the study of meaning, and we have pragmatics, because meaning is also determined by the social context, the interactional context, the cultural context in which a message is generated. So let's talk about these components in a little bit more detail, because I'm assuming that a lot of people that are watching are also radiologists, such as myself, despite the fact that this is not really a radiological topic, and this is all new. So I talked about phonetics and phonology, which both are involved with sound, the study of sound in language, and what is being studied in phonetics and phonology? Well, basically phonemes, the smallest unit of sound in a language system. Take for instance the word cat. The word cat consists of 3 phonemes. We have the K, we have the A, and we have the T, so cat. And these phonemes are important because if we replace a phoneme by another phoneme, we get a different word. For instance, if we replace the K by the B, we get bat. And bat is not the same as cat. It has a totally different meaning. So what is phonetics? Phonetics is basically the branch of linguistics that studies the physical and physiological properties of sounds. For instance, the letter K in phonetics. People who study phonetics will study how we articulate the letter K, for instance, how the letter K is produced, how it is transmitted as a sound wave into the air, how this sound wave is perceived by a listener. So it's basically the study of the physical properties of sounds. And phonology is a bit more abstract. It's also the study of sounds, but on a more abstract and cognitive level. It's basically how the letter K here functions to differentiate meaning. So if this would have been a B, we would have had a different word with a different meaning, how the letter K will pattern with other sounds, and so on. So to make the distinction real clear, phonetics is the study of letters, phonemes, as soon as they have left our mouth or vocal cord or whatever. So as soon as these become real physical entities. And phonology basically studies sounds when they are still inside our head, to make it really, really understandable or clear. But there's a lot of overlap between these two, and it's not always that clear. So then we have morphemes. What are morphemes, or what is morphology rather? Well, in morphology, is a study of morphemes, and morphemes are the smallest meaningful sound unit in a language. So basically, the word cat consists of one morpheme, cat. We need these 3 phonemes to get that one particular morpheme which has one particular meaning, namely an animal, a cat. If you look at the word happiness, for instance, we have 2 morphemes. We have happy, which also has meaning if it is a separate word, so not happiness, but happy. And then we have ness, which is something that is added to a word. I can't remember the correct English term. I think it's, you have prefixes, suffixes, it's one of those, never mind. So it's basically something that is added to an adjective to turn that adjective into a noun. So on its own, it doesn't really have meaning, but but it's another morpheme, and the word happiness consists of these two morphemes. Then morphology is, as said, the study of morphemes, the study of words and how words are formed. And then we have syntax, and syntax studies the structure of sentences, and it studies how words are arranged in a sentence. So where is the position of the verb, where is the position of the object, where is the position of the subject, and so on, because the position of a word in a sentence will determine the meaning of that word in that particular sentence. And then we have semantics and pragmatics. These basically both involve meaning, but semantics at a very basic level. Well, it's not that basic, but it's basically the branch of linguistics that studies meaning, and we can meaning. This can mean meaning at the word level, lexical semantics. What do words mean? And it can also be compositional semantics, namely meaning at the level of sentences, because a sentence will have a different meaning depending on the position of words in that sentence. And then we have pragmatics, which is basically the study of how context influences meaning. Take, for instance, the sentence, "Can you pass the salt?" Well, you could reply to that question as, yes, I can. I have two arms, they have two hands. I am able to perform the physical act of giving you the salt. So you can simply reply to that question, but that is not what is expected. When somebody asks you, can you pass the salt? That person is not inquiring if you are physically able to perform that specific physical action. No, it's actually a polite request if you could maybe give them the salt. So they basically expect you to give them the salt, and it's just, this is the way it is formulated. So that is what pragmatics is involved with, the study of meaning in a particular context. So to conclude, language has the following components. We have components mainly relating to the form. We have the content, we have use. So the components related to form or phonology, so the study of the sound units of language. We have morphology, so the study of words and syntax, the study of word order in a sentence. Then we have semantics, which is involved with what do words mean, what do sentences mean, and we have pragmatics, the study of meaning in a social context. And this is just, I've already used that phrase. These are just the various components of language illustrated. So if you have the phrase, can you pass the salt? You can analyze that at a phonological level. So what are the phonemes we encounter in this question? We can look at the morphology, and we see that each word consists of one morpheme in this sentence. We can study the syntax. We see that there's a modal verb plus a subject plus a main verb plus an object. We can analyze the semantics. Each word has a meaning over here, and as already said, from a pragmatical point of view, this is actually not a question, but it's a polite request. So language is a uniquely human trait. That's to say, a lot of animals are able to vocalize or use gestures or have certain ways of communicating with one another, but there is no species on this planet in which the language system is evolved in such a way that we are actually able to express an infinite number of ideas or thoughts. So we have this language system, and this language system is basically, it starts with a limited number of phonemes. I believe in the English language there are 44 phonemes. If you combine these, you get words. If you combine words, you get sentences, and then you have certain grammatical rules on how you can combine them on a word level and in a sentence level. These get meaning, and bam, you start with 44 phonemes and you have infinite possibilities. And that's really true. What you can do with language is really infinite. And I believe that is the main difference between a language as used by us humans and the various ways of communication that have been reported and described in the animal kingdom. And a person I'd like to mention here is Noam Chomsky, a very influential neurolinguist, was not just involved in neurolinguistics, also in mathematics, psychology, philosophy, even politics, and so on and so on. And in a time in which psychology was dominated by behaviorism, he actually said that language is a uniquely human trait. And what's even more, humans possess a language organ, which is a genetically acquired part of the human mind. And this is what allows us to produce and comprehend language the way we do. Basically, from a limited number of phonemes and syntactic rules generate an unlimited number of sentences. Now, this concludes this short introduction on what is language, because this presentation was going to be about the anatomy of language. And well, this was a very short introduction, but I'm a layman to the subject. So as said, I'm not a psychologist. I really had to read up on this subject to be able to tell you something about it. And I hope I didn't sell you a lot of nonsense, but I didn't. I really looked into the subject. What I do know a little bit about is anatomy. And everyone who studied medicine is familiar with the anatomical model of language, which is basically very, very simple. You have two areas in the brain. You have the Wernicke area, and this is the part of the brain that allows you to comprehend language, to understand language. And then you have the Broca area, which is the part of the brain located in the frontal lobe, which is the part of the brain responsible for language production. And the two are connected by a white matter tract, the arcuate fasciculus. This model is so easy and so simplistic that it truly cannot be right. That is to say, there has to be more to it. This is so logical because language, if you look at it from a linguistical point of view, from a psychological point of view, it is so complicated. There is so much that is involved in a language that this can't be the entire story from an anatomical point of view. And it isn't. But this is the model that was created historically and that was so influential that it is still being presented as the golden standard. So I'm going to discuss this model because there is also something to it. It's a bit outdated, it's a bit flawed, it has its limitations, but in essence, the essence of it is still kind of correct, as we will see during this presentation. So without further ado, let's get started with the anatomy of language according to the classical language model. And this story starts in 1861 in the Hôpital de Bicêtre in Paris. And of course, this start date is a bit arbitrary because before this time, people were already writing about the possible anatomy of language and so on. But one person was really influential in creating a breakthrough, and that was the French surgeon and anatomist Pierre-Paul Broca. Pierre-Paul Broca worked in the Hôpital de Bicêtre at Paris, and in 1861 he was asked to consult a patient over there, Monsieur Victor Le Borgne. And Monsieur Victor Le Borgne was a resident, had been a resident of the Bicêtre Hospital for a couple of decades now. So Monsieur Victor Le Borgne was a hatter. He made hats, I believed, but he started suffering from epileptic fits in his youth. And then somewhere in his 30s, he lost the ability to speak. He was admitted to the psychiatric department of the Bicêtre, and because there were no relatives that could take care of him, that's where he stayed for the next 21 years. Until he also developed, during his stay at the Bicêtre, a gradual hemiparesis of the right side of his body, but not acute. It was basically a gradual hemiparesis. So the story doesn't sound like he suffered an acute stroke, but it's a bit unclear what truly happened to him. But let's talk about his brain later. So this is his story. And in 1861, Pierre-Paul Broca was asked to consult because he had developed gangrene of one of his legs, I believe. And Pierre-Paul Broca was a surgeon, but also a surgeon who was very fascinated by the brain and who was well aware of the theories of his time concerning language. because in that time, the dominant view was that intelligence, language, higher cognitive functions, these had to be located diffusely in the brain. So the theory was, the view was quite holistic. But then you had also had people like Franz Gall, who believed that certain functions had to be located in specific areas of the brain. So that was the lay of the land in that period. And Pierre Paul Broca was aware of that. And then he got consulted or asked to consult upon this patient. And Mr. Victor Le Borgne had, as said, an impaired speech production, because when he could only respond to whatever question that was asked of him, like comment ça va, voulez-vous une bière, whatever, he could only respond with one word, temps, temps, and his nickname in the hospital was Monsieur Temps. No idea what it means, but it was the only thing he could produce. Nevertheless, he was intelligent. So Pierre-Paul Broca evaluated the patient, and it was clear that the patient was of normal intelligence and could actually understand everything that was being said to him. So unfortunately, Mr. Victor Le Borgne died because of gangrene, and Pierre-Paul Broca did what anyone would do under these circumstances. He performed an autopsy of the brain, and he discovered something peculiar. The brain had a lesion, a softening, as it was called in the study of Pierre-Paul Broca. So basically an area of tissue loss and gliosis, and something must have happened there. So whatever it was, no ideas. Was it a stroke? Well, the clinical history doesn't sound like it was an acute event, but whatever. So Pierre-Paul Broca observed tissue weakening or softening in the posterior 2/3 of the inferior frontal gyrus, so the lowest gyrus along the frontal convexity of the brain. And this is actually a drawing. I do not really know if it was drawing that is often reprinted, but was, I believe, first used by Pierre Marie and not by Paul Broca, but never mind that. And this is actually the brain of Monsieur Le Borgne, because Pierre-Paul Broca immediately realized that he was onto something. So he examined the brain macroscopically, but he did not cut it up because he wanted to preserve the brain in its entirety, because he believed that this brain might become very important for the history of medicine. And well, it actually was, or it did become important. So here we see the tissue defect located in the posterior 2/3 of the inferior frontal gyrus of the brain. So Pierre-Paul Broca immediately presented, or already in February 1861, presented his results to the French Society of Anthropology. That's right, not to a medical society, no, to the French Society of Anthropology, which was a society he himself had created and had about, I believe, 20 members at the time. And it was basically a society of very progressive free thinkers who believed in the theory of evolution and who were very interested in studying humans in a more objective scientific way. So anthropology, the study of humans, and of course how language, intelligence, and so on are generated in the brain is of course of tremendous interest to the members of this particular society. And you had two views at the time, and the dominant view, which was advocated by people like Louis-Pierre Gratiolet. The name might not say much to you, but he was a quite famous anatomist at the time. He is the person responsible for the fact that the brain is divided in a frontal, parietal, temporal, and occipital lobe, and then we have the insula, and then we have 5 lobes. So that's the guy who actually created that, or is responsible for that. Now, this guy believed that the language has no specific location in the brain. He believed that language basically was part of intelligence, human intelligence, and intelligence doesn't have one spot in the brain. No, it has to be located everywhere in the brain. And these holistic views were actually the dominant views of the day. But then comes Broca, presents his case, and says, no, I believe that language has a specific location in the brain, more specifically the inferior frontal gyrus of the brain. But of course, I only have one case, so I'll come back with more cases. And that he did. So a couple of months later, he saw another patient, Monsieur Lelong. And Monsieur Lelong was an 84-year-old man who suffered an acute stroke. And after that stroke, he had no hemiparesis. After that stroke, he could only produce like 5 words: oui, non, toi, with which he probably meant trois, and which he used to indicate any number, toujours, ever, and le lot, probably shortening of his name Lelong. So he could only say yes, no, three, always, and Lelo, indicating his name. And Monsieur Lelong also had a defect, but it was a lot smaller than the defect of Monsieur Le Borgne, and it was located over here in the posterior part of the inferior frontal gyrus, but once again posteriorly in the inferior frontal gyrus. So Pierre-Paul Broca certainly believed that he was onto something now, and by 1865 he had collected like 16 more cases, and all except for one had lesions involving the posterior 2/3 of the left inferior frontal gyrus. So basically, Broca observed two things, because I don't believe I have stressed that until now, so let's stress it now. All these lesions were located on the left side, never on the right side. So Pierre-Paul Broca believed that language is lateralized. It is located in one side of the brain, the left side, and this is since then called the dominant side, and that our ability to articulate language is located in the left frontal lobe. And damage to this area, to the posterior 2/3 of the left inferior frontal gyrus, will result in impaired language production, but language comprehension and intelligence remain intact. So, and this was revolutionary. Also important is, and this was stressed by Broca, this is not a dysarthria. This is not a problem involving the articulation of the words at a muscular level. So this is not a problem of the muscles of phonation and articulation. No, what is lost is basically the faculty to articulate language. So not articulation, but the faculty to articulate language. So basically a step above that, something higher, and let's call it language. So it's not speech deficit, no, it's really a language disorder. So the conclusions of Pierre-Paul Broca are: brain function is localized to the left, and we know now that, well, that's true for the majority of people, like 95% of right-handed people have a left dominant brain, and even if you are left-handed, you will still have left cerebral dominance in about 70% of cases. So brain function is localized, brain function is lateralized, and language functions have different components: production, comprehension, and formation, which probably have different anatomical substrates. So this was what the situation looked like in 1865. Pierre-Paul Broca had identified an area in the frontal lobe, more specifically in the inferior frontal gyrus, which later got his name, the Broca area, which he deemed responsible for language production. Okay, let's move on to the next player on the field, and that would be Karl Wernicke. We are now in Germany. We are in the Allerheiligen Krankenhaus in Breslau. So Allerheiligen, All Saints Krankenhaus Hospital. And Karl Wernicke was still an assistant physician over there. So he was still working on his PhD, I believe, but his PhD would prove to be extremely influential. And this is a copy of his dissertation. It was called Der aphasische Symptomenkomplex, eine psychologische Studie auf anatomischer Basis, or the symptom complex of aphasia, a psychological study of anatomy or of the anatomical basis. And this was, well, revolutionary, because we have all seen this drawing, or at least a drawing that looks like it. But this is where it all came from. So Pierre-Paul Broca had identified one specific region in the brain responsible for, which he deemed responsible for language production, but Carl Wernicke went a bit further. He described another language problem which was distinct from the language problem described by Pierre-Paul Broca. So I haven't really told you that yet, but we call these language disorders aphasia. Broca described a problem with language production. He had patients who could understand everything that was being said to them, but they were not able to generate language. And we call such an aphasia a Broca aphasia. Carl Wernicke described another form of aphasia in which patients are able to generate fluent speech, but their comprehension is impaired. This is difficult to understand, probably, but basically it boils down to the fact that these patients do not comprehend what you're saying to them. Nevertheless, they can generate speech fluently, but what they produce is basically nonsense, and they use a lot of semantical and the speech is filled with errors, paraphasias, semantical errors, neologisms, and it's also referred to as jargon speech or sometimes jabberwocky. And Carl Wernicke identified or performed autopsies in several patients with this particular form of aphasia, and he discovered that these patients tended to have damage in the region, the transitional zone between the temporal lobe and the parietal lobe. And this area would later be referred to as the Wernicke area, despite the fact that it is anatomically very ill-defined and it has never been well defined. So the Wernicke area is basically not so clear defined. Wernicke himself has never defined the particular Wernicke area. It was only later authors who said, well, this area is probably responsible for language comprehension. Let's call it the Wernicke area. So this is what did Wernicke do? He identified a different form of aphasia, sensory aphasia. Comprehension is damaged, but speech production is fluid. And he postulated a model of language. So this comes from the dissertation of Wernicke. Wernicke believed that in the brain, there are basically two main functions the brain fulfills. We have sensory functions and motor functions. And he believed that when a sensory stimulus enters the brain and the sensory stimulus is delivered to the brain through the spinal cord, the brainstem, and so on, all the way to the cerebral cortex, then this sensory stimulus leaves a memory image in the sensory part of the brain. So as soon as, let's say, we see something, then what we have seen will leave some kind of a visual memory in our visual cortex. That was a theory of Wernicke, and he believed that the same was true for the motor function. So if we perform a certain motor activity or we do a certain movement, a so-called movement image is created, which is located in front of the brain, so in the frontal lobe. And activation of these movement images can lead to movement. Now, Wernicke believed that the sensory system and the motor system were connected with one another, and he believed that these connections were actually quite variable. There was not one specific connection, and the strength of the connections also depended on how often they were used, and so on. But this is basically the thing Wernicke believed in. He believed this is how our brains worked, and he believed that this also applied to language. So this is a very similar scheme and this is the Wernicke theory of language. So we have an acoustic stimulus which enters the brainstem. So the sensory stimulus in this case is a spoken word, and which is transmitted to the temporal lobe, somewhere in the temporal lobe, the superior temporal gyrus, but somewhere there. It is not very exactly defined in the Wernicke model. So this spoken word reaches the superior temporal gyrus and it activates the word image, because he believed that a sensory stimulus creates an image, and this image is then stored in that part of the brain. So if we hear a word for the first time, like cat, that will generate a word image in the temporal lobe. And the second time you're confronted with that word image is activated. So when we hear a word, the word image in the sensory part of the brain is activated. And to pronounce that word, we basically activate the word movement image, which is located in the frontal part of the brain. And if that is activated, it will lead to movement, or in this case, speech. And the word images and movement images of words are connected with one another. And Wernicke didn't really know the white matter tract connecting the sensory language areas with the motor language areas, but that was later defined as the arcuate fasciculus. So a white matter tract connecting the Wernicke with the Broca area. So Wernicke was actually very vague about the location of his Center for Language Comprehension, and this is from his dissertation. And basically in this paragraph we see the entire Wernicke system. So the first temporal gyrus, which is sensory in nature, is the center of the acoustic images, or the word images, and this is also the region where the acoustic nerve terminates. The first frontal gyrus, which includes Broca's areas, is basically the region controlling the speech musculature, or the nerves controlling the speech musculature, which controls the movement images of words. So basically, Wernicke refined the model of Broca. So he added, well, he didn't really add a Wernicke area, but he postulated that there is a sensory system responsible for recognizing words in the superior temporal gyrus. Then we have the already known Broca area responsible for language production in the inferior frontal gyrus, and these are connected by a white matter tract, which was later defined as the arcuate fasciculus. Model of language. How does Wernicke believe language is processed and produced in the brain? Well, it all starts with speech input that is delivered to the superior temporal gyrus, more specifically to the auditory cortex. And at that moment in time, it was not yet known that the Heschel gyrus, located on the superior surface of the superior temporal gyrus, contains the primary auditory cortex, but there were already suspicions that it was somewhere over there. So speech input is delivered to the auditory cortex, and then from the auditory cortex reaches the auditory center, which later was referred to as the Wernicke area, and which is basically located in the vicinity of the primary auditory cortex, and which contains the word images. So it's the part of the brain that recognizes that what is being processed are words. But these words have no meaning yet. So it's basically just a lexicon, a phonological lexicon containing the words and the word sounds. But to activate meaning, other areas of the brain have to be activated. So meaning is not located in the auditory center. That's an important distinction. Then we have the motor center, which will be referred to as the Broca area, and the motor center basically contains the phonetic programs. It's the area responsible for speech production, and contains basically the word movements, as they are called by Wernicke. And these are guided to the motor cortex, which is located immediately behind the Broca area. And from the motor cortex, they activate our speech organs, the tongue, the larynx, and so on, and we get speech output. Now, this is the language model of Wernicke, but this model also accounted for the different types of aphasia that were already known at that time. So if you have a lesion in the auditory center, you get a sensory aphasia or a Wernicke aphasia, which is characterized by impaired language comprehension, but intact language production. But it doesn't make sense because, well, there is no feedback mechanism anymore. So because people cannot monitor their own speech, their own language, they basically generate nonsensical speech containing a lot of non-existent words because the phonological lexicon is damaged, of course. If you have a lesion involving the motor center or the Broca area, you get a Broca aphasia, characterized by an intact language comprehension, but a very impaired language production with a very effortful speech containing very few words, very agrammatic, contains very little function words, is sometimes also referred to as telegraphic speech because it is so short and effortful. And then Wernicke also predicted or suggested that there has to be something called a conduction aphasia, in which, well, language production and comprehension are intact, but people are not able to repeat what is being said to them because the connection between the Wernicke center and the Broca center is interrupted. And this type of aphasia actually exists, as was predicted by the Wernicke model. And this connection is the white matter tract of the arcuate fasciculus. And then if you have lesions involving both the Wernicke area and the Broca area, you get a global aphasia in which both language production and language comprehension are impaired. So this is the Wernicke model of language and aphasia. And this was, you had several other guys in that period who made some contribution to the study of language and aphasia. And the best known is probably Ludwig Lichtheim, because he made some very small, we have to say, adaptations to the Wernicke model to explain the existence of so-called transcortical aphasias. And what are transcortical aphasias? Well, these are basically your Wernicke and Broca aphasia, in which the patient is still able to repeat what is being said to him. And if we go back to this slide, well, that doesn't make sense, because if your patient has Wernicke aphasia, well, because the auditory center is damaged, a patient will not be able to repeat what is being said to him. If a patient has a Broca aphasia, well, the patient is not able to repeat what is said to him because you have an interruption on this pathway. So how to explain transcortical aphasias? How to explain that in some cases you have a person with a Wernicke aphasia or a Broca aphasia who is still able to repeat what is being said to him? Well, he said that's because the Wernicke and the Broca area are still intact, but what is damaged are neighboring cortical regions, which basically contain the semantical system, or the semantics, or the conceptual representations. And he added these to the diagram. So how to understand this? If you look at this, this is basically the Wernicke model, as I just showed it to you. And this is exactly the same if you look at this rectangle over here. This is the auditory input, this is the auditory center, this is the motor center, and this is motor output. So basically exactly the same as we see over here, but Lichtheim added this, the B. And it's very important that the B is not one specific location. No, what does B stand for? Well, basically the semantical system. As said, the motor center just contains the word images, so the phonetic programs. The auditory center contains the word memories, so the word forms, but does not contain their meaning. No, words get a meaning because a lot of other cortical structures are activated. For instance, let's say your auditory input is the word ball. So the word ball, oh no, let's work with cat. We've worked with cat a lot. Let's say the word cat is presented to you. So it is delivered to the auditory center, recognizes that this is a word. Then in the mental lexicon, the word cat is selected, but what is the meaning of cat? Well, then a lot of other cortical areas are selected. For instance, in the visual system, we automatically associate a cat with an animal with a specific shape, has 4 legs, has a head, 2 ears, and so on and so on, is furry, and this can activate certain areas in the visual system which contain visual information pertaining to cat. It can activate certain areas in the sensory system because these animals are quite soft when you touch them or stroke them, so these areas can be activated as well. And all these cortical activations combined actually generate the meaning. So what is a cat? Well, it's basically all these little things combined. So, and now the meaning is not located in the auditory center or in the motor center. No, it's located in cortical areas, well, located around it. Lichtheim didn't specify this. He also believed that it was actually could be quite elaborate cortical regions, and in that regard, he was not a strict locationist, to be honest. But he said this provides an explanation for transcortical aphasias, because if you get an interruption on the pathway between the cortical areas which generate the meaning of a word and the auditory center or the motor center, well, then no activation is possible of either the motor image or of the auditory image, but repetition is still possible. So you see what's happening here? We basically get an isolation of either the auditory center and transcortical sensory aphasia or of the motor center and transcortical motor aphasia. And certain words cannot be activated because there's a disconnection between their meaning and their motor image or their word image. But repetition is still possible because this pathway is completely preserved. This model is called Lichtheim's golden house or Lichtheim's house because it looks a bit like a house. And well, how did it happen? Nobody knows, but the Broca-Wernicke and Lichtheim were also pretty quickly forgotten. Immediately from the onset, the model was quite contested. There was a lot of debate. Holistic views were very dominant in that period. And let's say by the early 20th century, the model had basically fallen in disregard a bit. But then in the 60s, it was completely revitalized by Norman Geshwind, an American neurologist, worked in Boston. He actually pulled the classical model from out of the dust and integrated it with modern neuroanatomical and clinical data. He also added the angular gyrus to the language system because, well, I already told you I'm not talking about writing over here, but he believed he added it because he believed that is the hub that allows a visual information and auditory information to be translated into one another. And because of his work on the language model and aphasia, a lot of his colleagues or people in his hospital started working on aphasia, and Boston became quite renowned for its research on aphasia. And the Boston aphasia classification would be the dominant model for aphasia in the decades to come, I believe. So these are the landmark publications of Norman Geshwind, Disconnection Syndromes in Animals and Men, over 100 pages, published in 2 parts in Brain, and I believe it was 65, but I'm not sure. And then the Organization of Language and the Brain, also published. No, this was published in Science, also somewhere in the 60s. Very readable studies. I can recommend them to you. And this is basically the Geshwind model, which is basically the same as the Broca-Wernicke-Lichtheim model with the angular gyrus added to it. So we have primary auditory information, which is analyzed in the primary auditory cortex, of which we now know that it is located in Heschel's gyrus. And if there is a language information in there, that is passed to the Wernicke area. Now, the Wernicke area and the Geshwind model is kind of defined as the posterior part of the superior temporal gyrus located behind Heschel gyrus, and this contains still the center containing word information or word images. It's still the phonological lexicon, so to say. We still have Broca area containing the phonetic programs responsible for language production, and these activate the cortical areas for the larynx and the mouth, which are located over here in the precentral gyrus. So Wernicke area and Broca area are connected by a white matter tract, the arcuate fasciculus, and as said, Geshwind added the angular gyrus because he believed this was a hub in which primary visual information, so if you read something that is also language information but in a visual form, this needs to be translated into word information, and Wernicke believed that this happened by way of the angular gyrus, which is basically an intermodal area between auditory information and visual information. So it allows written words to be translated into spoken words and the other way around. So, okay, this is the Wernicke Broca-Lichtheim-Geshwind model, and is basically the model as it is still presented in literature and handbooks. It's still considered the golden standard when it comes to how does the brain process language, or how is language comprehended and produced in the brain. But it's a bit simplistic. So to conclude, I'm going to talk about the Boston aphasia classification, and I believe then we're done. So this is a very useful classification, or a very nice classification, because in Geshwind, everything finds its place. So we have this model. This model has certain anatomical areas. In these areas, we have certain linguistic functions, which are still very broadly defined as language production and language comprehension, but whatever. And correlating with these areas are certain aphasia syndromes. So everything comes together. And that's why I believe the model was so popular, because it explains so much if you were able to look behind, or if you were able to ignore the flaws or the moments where it just didn't seem to work. So what's the Boston aphasia classification? Well, it's a way to classify aphasia syndromes based on three components. Is the language fluent? Yes or no? Does the patient have an intact comprehension? Yes or no? And is the patient able to repeat? Yes or no? And we immediately see, based on these three questions, that we are basically inquiring if, well, fluency, is there involvement of the Broca area, yes or no? If a patient has no fluent language, Broca must be involved. Comprehension, Wernicke must be involved, and repetition, the arcuate fasciculus must be involved. So, okay, let's try it out. Does the patient have fluent language, yes or no? If the question is no, then we're dealing with, well, must be a Broca aphasia or a global aphasia. The next question, does the patient have intact comprehension, yes or no? If the question is the patient has no intact comprehension and is not able to repeat, then the patient must have a global aphasia. Then everything is involved, Broca, Wernicke, and the arcuate fasciculus. If the patient has no fluency but has an intact comprehension, then the patient is not able to repeat, well, that's a Broca aphasia. Then, if the patient is fluent, but has no intact comprehension, well, that's a Wernicke aphasia, and you will not be able to repeat. So we have basically already the three most important types of aphasia. The last one that's still missing is conduction aphasia, and in conduction aphasia, well, patients are fluent, have an intact comprehension, but they are not able to repeat what is said to them. So those are basically the four types of aphasia as already described by Wernicke: global aphasia, Broca aphasia, Wernicke aphasia, and conduction aphasia. And then Lichtheim managed to explain the transcortical aphasias, which are basically global aphasias, Broca aphasias, and Wernicke aphasias, in which repetition is intact. So if you have a Broca aphasia, but with preserved repetition, you have a transcortical motor aphasia. If you have a Wernicke aphasia with intact repetition, you have a transcortical sensory aphasia. And if you have a global aphasia with preserved repetition, you're basically having a transcortical mixed aphasia. The final type of aphasia is anomic aphasia, and that's a very peculiar one. It's a type of aphasia which is dominated by severe word-finding difficulties, so like an internal tip of the tongue phenomenon, but language comprehension and production as well as repetition are all preserved for the rest. So the only thing these patients have, well, only thing, are severe word finding difficulties. And this type of aphasia is basically difficult to explain by using the the Geschwind model of language, and doesn't have an exact anatomical correlate. The other ones do. So I made some drawings. So over here we see a Wernicke area. This is the Broca area. And each type of aphasia in the Boston aphasia classification system has its anatomical correlate. A patient with a Broca aphasia must have a lesion in the Broca territory. With a Wernicke aphasia, it must be in the Wernicke territory, and with a global aphasia, it must involve both. In a patient with a transcortical motor aphasia, the Broca system is isolated from the surrounding cortical areas, so no semantic information is able to reach the Broca area, but the arc between the Wernicke and Broca area is still intact, so repetition is possible. In transcortical sensory aphasia, something similar is happening, but in this case, the Wernicke area becomes isolated from surrounding cortical regions containing semantic information. And in transcortical mixed aphasia, we see that the arc from the Wernicke area to the Broca area is preserved, but the Broca and Wernicke areas are isolated from surrounding cortical structures. Then we have conduction aphasia, which is basically a lesion disconnecting the Wernicke area from the Broca area. And finally, we have anomic aphasia, which has no specific anatomical correlation. Okay, so to summarize, the Broca-Wernicke-Lichtheim-Geshwind model started with Paul Broca, who discovered that language is localized and lateralized in the brain, and that the left frontal lobe, more specifically the inferior part, the posterior part of the inferior frontal gyrus, contains an area that he considered responsible for language production. So Paul Broca basically caused the birth of this language model. Then, about a decade later, Carl Wernicke is there, and Wernicke introduced this more sophisticated language model that was able to explain various aphasia syndromes like the Broca aphasia, Wernicke aphasia, predicted the conduction aphasia, and so on. Lichtheim completed the model by introducing the semantic system, which has no real location or not a specific location, but by adding it, he could explain why there is such a thing as transcortical aphasias. And finally, after this system or this model got kind of forgotten for half a century or so, it was revitalized by this guy, Norman Geshwind, and with a lot of success, because the model now is, I believe, still the dominant model when it comes to the anatomy of language in the brain. But it has its limitations, and I'm going to talk about what these limitations are. And it's not that difficult. Basically, it's just not going to say it's incorrect, but it's too simplistic. It's too simplistic when it comes to anatomy, it's too simplistic when it comes to aphasia, and it's too simplistic when it comes to its psychological description of what language is and how language functions. Let's start with aphasia. Why is the anatomy, I believe, I was going to say, why is the anatomical model too simplistic? Well, that has to do with the way the anatomical regions were described that were deemed responsible for language. In those days, the only way to examine brain function was by studying brains of patients with a certain disorder, in this case aphasia, after the patient had died, and by detecting a certain defect in a part of the brain in a patient with aphasia, a causal relationship between the two was assumed. It was believed that the aphasia was caused by that particular defect. And of course, that's an assumption. And well, these post-mortem studies are, of course, have their limitations. First of all, the precision is quite limited when it comes to the study of brain-behavior relationship. In this model, the focus was mainly on two language centers, but these were, and we will see this, were not that well defined, especially the Wernicke area. And the model also focused tremendously on defects in cortical structures, but it ignored subcortical structures and the connections between these structures. So this is from a publication in 1976, and it's titled Wernicke region, where is it? And that was a good question because, as said, Wernicke never really specified where he believed the auditory image center would be located. This was from his dissertation, and he put an A over here, indicating that this is roughly where he believed the auditory center, language center was located, but he did specify it exactly. And he did that deliberately because he also didn't really believe that there was going to be one specific location in each and every patient. He believed it would be located somewhere over there, and that sufficed. As said, Wernicke was not a very strict locationist. Something that is sometimes forgotten. And he was very critical when it came to the idea that these kind of areas could be exactly located in the brain. This comes from a follow-up publication a couple of years later. It's basically the same, but here he put some lines in the superior temporal gyrus, so it's a bit better defined, but it's still very rough. It's an approximation, and that was deliberately done by Wernicke. So his area is like somewhere over here, and that sufficed. Nevertheless, if you look at diagrams that are being used in publications and handbooks, often you see a very well-defined area in the brain that is called the Wernicke area. Where does that come from exactly? Well, that's a bit unclear because if you look at it historically, and this is a very nice overview published in Brain and Language in 2016, of how the Wernicke area has been defined over the years by several authors. And you see that this definition varied tremendously. So Wernicke was quite vague, somewhere in the superior temporal gyrus, and then you had other authors who were more specific, who narrowed it down a bit, like Geshwind and Nielsen. Others who added parts of the parietal lobe, like Lewandowski and Penfield and Roberts. And finally, you have Geshwind, who narrowed it down to a small posterior part of the superior temporal gyrus located behind the primary auditory cortex, because, well, that kind of makes sense. And this is how it is most often presented in handbooks nowadays. The way Geshwind defined it as the Brodmann area 22, the posterior part of the superior temporal gyrus. But as said, it's quite arbitrary, come to think of it, especially if you see how often the definition has changed over the course of more than a century. And the authors of this publication basically concluded, well, Wernicke area is the area where a lesion will cause a language comprehension deficit, and I believe this is probably the most correct definition of the Wernicke region. So the Wernicke region is ill-defined, and that is something we will have to accept. The Broca area is a bit better defined. It consists of the triangular and the opercular part of the inferior frontal gyrus. So the inferior frontal gyrus typically has an M shape, and the triangular part is like the middle part of the M, and the opercular part is like the final limb of the letter M. And as such, the Broca area is actually quite well defined as these two components of the inferior frontal gyrus, boiling down to the original publications by Broca. But then the question is, okay, so this is Broca area based on the initial studies by Paul Broca, but maybe we should look a bit more carefully at these studies, because how correct were they? This was the brain of Victor Le Borgne. Did he truly have only damage in the Broca area? Well, no, he didn't. And Broca already told us so in his initial publication, that the patient had more extensive damage located subcortically, but he could not tell us how extensive it was because he decided to not cut up the brain. So he believed that the superficial damage in the cortex of the inferior frontal gyrus was responsible for the speech or language production deficit in his patient, but this was an assumption, and he basically ignored the fact that the patient had a lot more damage than just that. This comes from a study published in 2007. In the 70s and 80s, CT images, because the brain of Le Borgne was preserved, it was possible to perform CT and MRI studies of his brain. And this is from CT studies published in somewhere the 70s or 80s, I believe. And these show us that the deficit is a lot bigger than just the posterior part of the inferior frontal gyrus. There is a lot of tissue loss involving subcortical structures, as you can see on these images. So why did Broca believe that it was just the cortical area of the inferior frontal gyrus that was responsible for the aphasia in his patient, and why did he ignore these large areas? It's basically a bit hard to believe, and it seems quite selective. These are MRI images of the brain of Victor Le Borgne, and over here, okay, here we have a defect in the inferior frontal gyrus, but we also see a defect involving the superior temporal gyrus. The insula seems damaged, as we can see here. We see that there is a large area of subcortical tissue loss. So on MRI, basically confirms what we already saw on the CT images. The damage is a lot more extensive than just the inferior frontal gyrus. So what is involved? Inferior frontal gyrus, but also inferior parietal lobe, anterior temporal lobe, insula completely destroyed, and several subcortical structures such as the lentiform and caudate nucleus, the claustrum, and the internal and external capsule. If we then look at Monsieur Lelong, we see something else. Namely, the patient had severe global atrophy, but I already indicated the inferior frontal gyrus. What do we see? Well, it looks mostly normal. And that's correct, because the damage was extremely limited to only the most posterior part, the opercular part of the inferior frontal gyrus. And you can't even see it that well on these images because the damage is hidden by the red coloring I did to indicate the inferior frontal gyrus. So, okay, this basically makes us question a bit the validity to call out the inferior frontal gyrus as the seat of language production based on just these two cases, because in the first patient the damage is a lot more extensive, and in the second patient the damage is extremely limited. So, well, let's just say that two patients is simply not sufficient. Nowadays you couldn't do that, I believe, say when I have discovered the seat of this particular function based on the study of one or two patients. Okay, another problem, so we have the anatomical problem, the fact that you can put some questions with the anatomical locations provided by the Broca-Wernicke model. Then there's the problem of aphasia. So the classical model tries to explain several aphasia syndromes, also by correlating them with the location of certain brain lesions. But that's also based on an assumption that the location of lesion will produce the aphasia syndrome and the other way around. And in daily practice, this just doesn't work out. This is from a study in the 70s. So one of the problems was that it was only possible to examine the brain of a patient with aphasia after he had died. In the 70s, suddenly we had CT, and these early CT scans look like this. So this is an image from this initial publication or this original publication. But nevertheless, we see a large defect over here. And in this publication, it is now possible to study the brains of patients with aphasia that are still alive. And the authors examined patients with Broca aphasia and showed us the location of the defects. And there are some things that jump to the eye rather. For instance, take this patient. This patient only has subcortical damage involving basal ganglia or white matter tracts and the frontal lobe, but there is no cortical damage over here. Here's another patient where is damage to the inferior frontal gyrus. There simply is none. Imagine that this would have been Broca's original patient. Would we have a Broca area then? That is the question. We also see that the damage can vary extensively. Here, there is damage in the cortex of the inferior frontal gyrus, but also in the insula and in the temporal lobe, as you can see. But over here, the damage is extremely extensive. So there is an incredible variability in how extensive the lesions are. And the conclusion of these authors is actually saying a lot. Our data indicates that infarction of the Broca area produces neither Broca aphasia nor any persisting aphasia. So if you have damage solely located in the cortex of the inferior frontal gyrus and the Broca area, the patient will not have a Broca aphasia or a persisting aphasia. Broca aphasia is only seen as a residuum of a larger infarction, for instance, like this patient over here, which initially produces a global aphasia. So basically, what these authors are saying is the Broca model is not completely correct. It doesn't work out in daily practice. There's another study from the 70s, also a CT study, comparing the lesions in patients with Broca aphasia and Wernicke aphasia. Now imagine one of these patients was the original patient of Broca. The story would be different. I have colored in the Broca area for you. And if we look at the patients with the Broca aphasia, we see that in several patients, the Broca area is not involved or minimally involved, not in all of them, but in some. So I believe there is basically no patient in which the Broca area is completely involved. If we then look at patients with Wernicke aphasia, we see that if we use the Geschwind definition of the Wernicke area, that the Wernicke area is in some patients not involved or only partially involved. If we then also look at the Broca area, we see that in this patient who clinically had a Wernicke aphasia, we also have a lesion in the Broca territory, and the other way around. If we use the Geschwind definition of the Wernicke area, we see that in patients with a Broca aphasia, we also have lesions in the Wernicke region. What can we conclude? Well, I think we can only conclude that the classical model is not completely correct, because if it was correct, this should not be possible. So we have, on the one hand, very heterogeneous lesions in patients with the same aphasia subtype. And this is kind of to be expected, because these patients have strokes, and strokes will have vascular patterns, but these will vary tremendously between patients. But we also see that in patients with similar lesion sites, these can have different aphasia subtypes. So basically the model is flawed and cannot predict the aphasia subtype based on the lesion site or the other way around. It's the only explanation you can give here. This is the Boston classification of aphasia. So as I said, it's a beautiful model because everything comes together. You know, aphasia, the site of the lesion, and so on. It's very handy, it's beautiful, but in practice, a lot of patients with aphasia simply do not fit into any of these categories. So we have 8 aphasia subtypes, and about 25% of patients in this particular study, but I've seen other studies with similar numbers, simply can't be classified by using the Boston aphasia classification, and that is a lot. What's even more, let's go there, up. There is no lesion syndrome match in more than half of patients. So the classical lesion syndrome match, as predicted by the model, simply doesn't come true. Then there's the fact that the model is based on things like fluency, comprehension, repetition. These are very generic terms which have no real linguistic meaning because, as said, language is composed of stuff like phonology, semantics, morphology, syntax, and so on. Fluency, comprehension, repetition or just some superficial characteristics of language that have no real cognitive value or no real linguistic meaning. Then in patients with the same aphasia subtype, there's a lot of heterogeneity and task performance and severity. So you can have a patient with a Broca aphasia who is barely able to mutter a word, and you have patients with Broca aphasia that can actually put up a conversation, be it with a lot of trouble and a lot of effort and a lot of difficulties in finding the correct words, but they're able to communicate in a way. So there's a lot of variability there. And lastly, the aphasia subtype can change over time because the brain is very plastic. The brain connections can change. We can impact of therapy can have an influence and so on. So this also creates problems. Then there's the problem of the classical language theory, which is a bit simplistic because, well, basically you have a production center, the Broca area, and a comprehension center, the Wernicke area, and that's it. Language is more complicated than this. Like I said, how do you account for phonology, morphology, syntax, semantics, pragmatics, and so on in this model? You can't. And these are also just the superficial characteristics. Yeah, if we really go into analyze language deeply, well, it has a lot more components than these. So, in short, the Broca-Wernicke-Lichtheim model falls short, has its limitations, but this is nothing new. This is a nice study published in 2016, but I'm a bit bothered by the title. It says Broca and Wernicke are dead, or moving past the classical model of language neurobiology. It's a good article published in 2016, but the authors make it seem as if they are onto something new, and they are not. You know, the Broca-Wernicke model has been disputed since its early days. Wernicke region, where is it? Published in 1978. This is from 1906. Existo ono un centro de Broca. Does the Broca area exist? Published in 1906. So it has always been there. It has always been clear that the model is a bit flawed, is not completely, but it's beautiful, I have to say. So let's not throw out the kids with the bathwater, as they say. What is correct, I believe, is that these guys identified a language network. They didn't immediately call it a network, but they basically identified a language network in the left frontotemporal brain region. They did that in a time where the views were very holistic, but they said no, language, left frontotemporal region, end of story. And they were correct in that regard, because that has not been disputed, not by anyone, that the language is a separate faculty that is represented neurologically in that specific area. And maybe they were a bit simplistic when it comes to the exact anatomy and so on, but their only means to study language was by performing post-mortem studies, which is not the ideal way to study a brain, of damaged brains, so not of healthy brains. Their views of language are often presented in a very simplistic manner. So you have language production, language comprehension. If you read their publications and you read them well, you will notice that guys like Wernicke and Lichtheim actually spent a lot of time contemplating about what language really was, how it works, how the brain processes it, or probably processes it, and it's a lot richer, deeper, and more critical than is presented nowadays. So we should do them right by actually admitting that they weren't that stupid to simplify language that much, but it has been done in handbooks and textbooks following the description of their model. They had these diagrams, and some of their enemies called them the diagram makers, belittling them a little bit. But for them, these were just schemes to make it more easy to understand. As said, Wernicke, they never specified the exact anatomical location of the auditory word area, and he didn't find it that important, even somewhere in the temporal lobe, and that was sufficient. For him, it was more about the model and the idea how language gets processed exactly. So they were no strict locationists. Wernicke and Lichtheim definitely weren't. So that concludes this presentation. Coming soon, the second part, which will be about studying language and a healthy brain. Because as said, so the classical model has its flaws, but that has a lot to do with the fact that the only way to study the brain was by performing autopsies of damaged patients, of damaged brains. Now we have tools like functional MRI, PET, and so on, which allows us to study the brain in healthy living patients, and that makes a lot of difference. And we will also move from brain topology, so the belief that a very specific cortical region of the brain is responsible for a very specific function, to tracts and networks. And we will see that functions are not performed in one specific cortical region, but will involve the collaboration of several connected cortical brain regions. So there's an evolution to a more functional anatomy of language. So that will be for the next presentation, an overview of PET and functional MRI studies on language and the healthy brain, and a description of current more functional theories of language organization in the brain. For people who are interested in this subject, I find it fascinating, I have to say. I can recommend these books, Neurobiology of Language by Gregory Hickok. It's like 1,000 pages. It's I'm not going to say I read it, but I used it to look up some things because I'm a layman in this subject. And this is actually a good book if you want to have the idea of this contains everything. Now it's just a matter of finding it. And this is also an excellent book, the Broca-Wernicke Doctrine. It's more a historical book telling us the various theories on the anatomy of language from the times of Broca and Wernicke until now. I can recommend it warmly. It's a really good book. So that concludes my presentation. If you have any questions, comments, or feedback, leave a question, comment, or some feedback in the comment section, or send me an email, neuroradiology.online@gmail.com. Thank you very much for watching.